the C-arm must be in a perfect position to have a good view, a good AP view, and a good lateral view. Usually my patients are on a table in a supine position. The foot is off the table, and by this I have the possibility to go with my C-arm directly in a posterior anterior view to see where the bones are, where is my burr, where I can do my cut, and how I can achieve my right correction and the right position for my screw. Also, it's important to have a right lateral view. For this, you can bend the knee, turn the foot, and additionally, if you have the advantage to have a small C-arm, you can move the C-arm around and have a good lateral view. In open surgery, we use usually a tourniquet. It makes much easier to see the tissue, to see the bone, to see a correction and find your way through. It's much easier for you. The way of MIS is it's no need for that. Especially a tourniquet is stopping your bleeding, and bleeding is what I like to have it on my MIS surgery, because bleeding is cooling also. So we have the blood is coming out of the small incision. It's not that amount, but it's still cooling, and it's getting out the debrided tissue, the bone, also by this. So no tourniquet anymore to use, especially if you work with only a block, a foot block. It's much easier for you to avoid a tourniquet, less pain for the patient. It's not necessary to do a high block or to a full anesthesia just because of the tourniquet. So additional benefit to avoid a tourniquet. It makes sense to mark your landmarks before you start the operation, to always to know where you are exactly, and to avoid damages and to avoid any undercorrection or malcorrection. So what I usually do when I go for the first ray, I mark the TMT1 joint. Usually you can feel it for the beginning, and also later I usually do an X-ray. I take my burr, mark my position where I think and now I'm nearly at the TMT1. So I mark this place. This is my TMT1 joint. So the MTP1 joint is quite easily to define. You can feel it, but the important thing is to know the way the metatarsal runs. It's plantar flexed. So you have to be sure that you mark the plantar aspect of the first metatarsal bone. It's like that. And then you can mark the position of your cuts of the for the mica or for any other ways of distal correction. It's outside the joint. It's extra articular, and it's this is the proximal part of the metatarsal. And I usually start in the middle if I do a transverse, or a little bit more proximal if I do a chevron style. The placement for the screws are like here and here. It depends on your jig, but usually if I do it freehand, this is the position for the screws. The dorsal nerve, it's running like that way. So you should be aware of this nerve and stay away from this. Patient would have some problems, disturbance in the distal part, numbness in that area. You can avoid this if you know that the nerve runs like here, and try to be aware of this. Then you can mark the metatarsal head, like here, and the phalanx like that, and the head is going like here, like here. So if you go in with your cut, it's that area. Before doing any cuts, be sure about your position of your incision. For this, I do a true AP and do an X-ray and mark my position. So here will be my starting point for the chevron technique. The chevron technique has a short dorsal and a little bit longer plantar part. Now I do my first incision. It's in this technique, in that area, directly to the bone, and that's all. After doing your cut, you need to create a safe space for your burrs. So try to go in with a rasp or shove something sharp and bring it down so you can mobilize it a little bit. We have different ways burrs look like. It's not only the size, means the length of the cutting part and the diameter. It's also the shape of the burr itself. And this depends on what you would like to use it for. So if you compare those both, they have the same shape. They're called the Shannon burrs, but a different size. And the different size is because of different size of the bone. We are working with the burr always from inside the bone to outside. So if it's longer, you're in trouble maybe damaging soft tissue. So this 20 millimeters is the perfect size for the first metatarsal. By this, you can cut with the sharp Shannon burr directly straight cut through the metatarsal. If you're in the second metatarsal bone or in the phalanx for an Aiken osteotomy, this 30 millimeter is perfect size for this. So you can work from inside to outside without over lengthening the burr inside the soft tissue or not to be deep enough into the bone. Different thing is the wedge. The wedge itself comes in two different sizes. This is a 4.3 millimeter in the biggest area here at that point. It's not too long because it's just for taking off exostosis for diabetic patients or for the exostosis in the metatarsal head or for Haglund. It's this, and here we are not working from inside to outside. We just above the bone, above this exostosis, and getting it done from outside. This one is an 8 millimeter length cutting area of this burr. The style is different. It's called an helical. This one is much easier to drill inside the bone, especially if you have a hammer toe correction and the bone is not so big. So it's an 8 millimeter one, and you can do your cuts and do small drill holes. And this is the reason why it's a helical one. For the first cut for the mica, I prefer 20 millimeter long burr. The size is 2.2. That's the perfect size for me. The first cut is the place we already marked. And then we will take off at least 2.2 millimeters of bone, and we don't want to have too much shortening. So this is the reason I'm tilting it I'm pointing more to distal. I try to go to the second metatarsal head. Usually this is fine, but don't rely on this totally. Take an X-ray, and this is the position I would like to have it. This is my position. We have a plantar directed and distal directed burr. So in this position, I usually start to go in with my burr. So now I'm through the second cortical bone, as you see it here. It's totally safe to get a little bit more inside. The nerve and the vessels are at least 0.6 centimeter far away from the metatarsal. In this position, this is the center of your rotation for the chevron. In this position, you're now tilting proximal dorsal, and for this, don't shift your burr, just tilt it. Easier if you take your hand like that, and then you can feel it. You're going directly through it. So then pull it back and do the same plantar ward. Just shifting, tilting, not shifting. And as soon as you completed the cut, you will feel it with your left hand. So now it's open. Now we have finished the cut for the mica, and the X-ray shows that we directly went through the metatarsal at the right spot. And now you can use a clamp or rasp to shift the head. Just go inside the bone. And this is important. Try to avoid tilting to dorsal or to plantar. You can manage this if you take the head with your left hand for a right-hander or the other way. And then you shift it, and you can additionally by holding it with your fingers, adjust the rotation. Usually we have to also to do a rotation correction, and this is the position I hold the head, avoid a plantar flexion, a good correction of the first bone, and now we do an X-ray for this. Now you see really smooth correction on the right place. The really good and technique is to take a look at the rotation, and for this the lateral border of the metatarsal head should look like this, should look like in 90 degrees. So we have a three-dimensional correction. We correct any shifting in an intermetatarsal angle. We try to avoid the tilting of the head, the plantar and dorsal, and we have to correct the pronation. If you look to this X-ray, in this X-ray we have a good shift. The sesamoids are not really in a nice place till now, but the shifting is good. But if you look to the lateral border, it's curved. And if you look, this is a sign for a good rotation correction. If you compare this, we would like to have this nearly 90 degree at a distal point. This shows you a good rotational correction. And by this, it's not more shifting. If you recognize the both X-rays, it's just rotating. And if I do the rotating, the sesamoids are in a perfect place now. This is a good X-ray. I will take this, and then you can go on with your osteocentesis. Another point I would like to mention on the normal AP view, where you can see maybe some positioning that are not the way I like to have it. If you look to the head, it's curved. And compare this to this view, you see like a dome shaped in the center. And this is a sign for dorsiflexion of the head. As soon as you see this, go back, check your lateral X-ray, and try to get the head in the right position. The next thing would be to bring in your key wires and your screw for the fixation. Therefore, just open the system and bring in the handpiece for the key wire. It's cannulated, so it's run the way you would like to have it. And before I do it, I go back to my incision marks and be sure that I'm in the right position. I could be a little bit more proximal. This is a fine place for me to go in. And my key wire would like to run this way to the head. So for that, I can mark, I go in for my incision and do opening the skin just to the bone, and then adjust my X-ray to have a good overview and go in with my key wire. This is the way I would like to have my key wire and my screw later to fix the bone. Important thing for me is to have a bicortical fixation in the metatarsal and to stabilize the lateral part of the head. I would like to be at least 1 centimeter or away from my osteotomy. The next point is to bring in the key wire in the right position. For this, I use the cannulated AO model and go in this position. Avoid to be too much plantar, because the metatarsal is bending on the plantar aspect, and you're maybe in trouble if you're running out plantar from the metatarsal. Then I point to that area what I would like to go in. You can take an X-ray if you would like to be sure. My left hand holds my correction. So the clamp is shifting. My fingers are controlling the rotation. And my index finger is pointing me the area I would like to go, and also is controlling that I'm not extended or plantar flexion the head. So the metatarsal is like that, as I showed you before. So this is the way you should go with your key wire. Then you feel the second metatarsal, and I think we are fine. Perfect. This is the way I like it. This is the way my QI would like to have it. If you look to this toward the first metatarsal bone, it's mid-shaft, so you're not running in trouble to have a cut of the plantar, to have the key wires running out plantar or dorsal, and to have a good correction. The second screw, it's not necessary to have it in a bicortical view. It's just the cortical, and it avoids rotation insufficiency. So this is the reason I go in my area. Okay, the second key wire is fixing just that cortical bone and this in cancellous bone. Just the rotation stability, which gives you more stability at the end, but it's not necessary to go to the second cortical bone for this. As soon as you're happy with the position of the key wires in the head, you can start measuring the length of the screws. This one is measured at 50. We have to do an incision. It's a 42. Now we can drill the holes for the screw fixation. For this, you have to change from the key wire to the cannulated AO drill. Just fix it, and then you are able to put in your drill and go in. I try to avoid to bring in a lateral screw without fixating the head with the second key wire. So I always have two key wires in. It's cannulated, so it's quite easy to hold it. And then I do the first cortical, the second cortical, and I'm just a little bit inside the head, and that's all. Now we can bring in the first screw. I start with the proximal screw, and you can use this screwdriver with this AO coupler, or use it by hand. It's up to you. So now we bring our screw in. The reason why I start with the lateral screw is this is my screw which brings me fix my position. The lateral screw is the screw which is the important screw for me, and this is the reason why I start with the lateral. Important is to fix the head with the second key wire and then maybe an additional key wire, because if you only have the proximal key wire and the screw is coming in, you may be in trouble of tilting. So this is the reason why I have it fixed in the right position. And then I start with the proximal, and the second screw is just the rotation stability for me. So after shifting the head in the position you would like to have it, then you have to fix it with the screws. You have still now the prominence at proximal to your osteotomy. Doing this, I start usually with the burr, and I start with the burr system. I change from the cannulated RO model to the burr model. For cutting down the prominence, the wedge is great, but usually I start with the 20 millimeters to get the first amount of bone away, and then the wedge is much more powerful if you have cut a little bit the exostosis down and you have space for your cutting. For this, you have two different ways to go in. If you go through the area where your osteotomy has done, it's sometimes a little bit difficult to get it in. For me, it's easier to go at that area of my distal screw. The screw is already in, the skin incision is already done, so I can go in directly pointing to that area. So before going in, I go in with the rasp. I prepare a soft tissue space to get this soft tissue away from the bone. Then I go in with the 30 millimeter and do an X-ray just to check if I'm in the right place. You see it here? And then you can take off the first amount of bone of this prominence by doing this movement. As soon as I have to reduce it, or I change to the wedge. This is much more powerful and faster for you, and go again inside the bone area, and then let's check it. It's gone. If you're taking off exostosis or osteotomies to flush it out, you can use for this a syringe or something else to flush the whole bone debris out of the area. So by this technique, you can take off the medial amount of bone which is prominent after shifting the head to the lateral. You can do it like I showed you from the incision of the distal screw, but you can also do it from the osteotomy side. For the handling, it's a little bit easier to come this way, and also you're away from the capsule. The amount, how much I would like to take off depends on my shifting. I don't want to take off an area where I have bone contact. And the other aspect is the feeling. You can feel it on the foot, if there's a prominence, if there's any area which is still prominent at the medial side of the metatarsal, then go and cut it down as much as you would like.